One, we are live.
Yeah. Welcome for this, I would say, very important one of the CME. First, I'd like to welcome our president, Dr. Swas Pingle sir, very active and taken, I would say, this very important topic as there is outbreak of new communicable disease, monkeypox, spread in about 72 countries. WHO announced it as a public health emergency, being an international concern. There was also first death, a 22 years male had succumbed. Here we have about two experts, Dr. Anand Bhave sir, Dr. Priti Pillai ma'am. So I'll first welcome all of the delegates and main our president, Dr. Suhas Pingle sir, ever dynamic and always enlightening us on very new topics. So I welcome Dr. Pingle sir. Our honorary secretary is busy somewhere and in transit also. I welcome Dr. Mangesh Pate sir, our president-elect, Dr. Ravindra Kute sir, Dr. Ramkrishna Londe sir, our past president, Dr. Rajiv Agarwal, honorary treasurer, our director, Dr. Pradeep Kumar Sangre, who has taken great efforts to have this important CME on monkeypox. So also I welcome our joint secretary, Dr. Jagdish Ramchandani, Dr. Bhavika Chandani, honorary joint secretary. So also IMA Kalyan president, Dr. Prashant Patil, they being co-host for this important of CME of monkeypox. IMA Kalyan is holding this CME. Next, I welcome Dr. Isha Pansare, Vice President, IMA Kalyan, Dr. Surekha Litkar, Honorary Secretary, Dr. Himanshu, Treasurer, IMA Kalyan, my friend Dr. Rajan Mane, Assistant Secretary, CGP, Sub-Faculty, IMA Kalyan. So I again welcome our experts, Dr. Anand Bhave sir, Dr. Priti Pillai ma'am. Now I hand over the charge to Dr. Sangre, who will take over and brief about the events.
Thank you, Dr. Rajan Sancheti sir. Thank you very much. Now I request Honorary Secretary IMA Kalyan, Surekha Ipca madam, to welcome on behalf of IMA Kalyan and sub-faculty CGP IMA Kalyan.
Good evening to all respected dignitaries, speakers and delegates. On behalf of IMA Kalyan, I, Dr. Surekha Ipka, Secretary IMA Kalyan, heartily welcomes you all. It gives me immense pleasure to welcome today's guest, respected Dr. Suhas Pingle sir, who is the President of IMA Maharashtra State, Dr. Mangesh Pate sir, who is Honorary Secretary IMA, Dr. Rajiv Agarwal, Dr. Ramkrishna Londe sir, Dr. Ravindra Kute sir, Dr. Pradeep Kumar Sangle sir, Dr. Rajan Sancheti sir, Dr. Jagdish Ramchandani sir, Dr. Bhavika Chandani ma'am, IMA Kalyan President Dr. Prashant Patil, Isha Pansare, Dr. Himanshu Thakkar, and our Honorary Secretary Dr. Rajan Mane sir. I welcome today's distinguished speakers, Dr. Anand Bhave sir and Dr. Priti Pillai madam. I once again welcome you all for today's informative webinar on Now Be Prepared for Monkeypox. Over to you, Dr. Pradeep Kumar Sangle sir.
Thank you, Ipca madam. Thank you very much. I now request Dr. Ravindra Kute sir, President-elect, to address the gathering. Kute sir.
Hello. Good afternoon, everyone.
Good afternoon.
Yeah. President IMA Maharashtra, Dr. Suhas Pingle, Dr. Mangesh Pate, Secretary, Director of Studies, Dr. Pradeep Sangle, Secretary, Dr. Rajan Sancheti, our Joint Secretaries, Dr. Ramchandani, Dr. Hot Chandani, President IMA Kalyan Branch, Dr. Prashant, Dr. Itkar Madam. First of all, congratulations, IMA CGP Maharashtra Wing, and especially Dr. Pradeep Kumar Sangle, who is the director, for continuously arranging CMEs on behalf of CGP for IMA Maharashtra. He has chosen every time very important and CMEs on burning issues. And today, our speakers are Dr. Anand Bhave, Dr. Priti Pillai, and the discussion will be on monkeypox. There are emerging cases, and this topic needs to be discussed in length. So, my best wishes to today's CME. Thank you.
Thank you, Kude sir. Thank you very much. Thank you very much. Now I request our Honorable President Suhas Pillai sir to address the gathering and to inaugurate today's scientific session. Over to you,
Thank
Pillai
you,
sir.
Dr. Sangle. I welcome you all on behalf of IMA Maharashtra State, all the dignitaries and the delegates. This is a very pertinent topic today, burning topic, and I am very thankful to Dr. Sangle and his team. So let's hear the experts and be prepared for this monkeypox onslaught. Thank you.
Hexagon team. To Sangle.
Dr. Sangre,
Dr. Sangle.
It needs to be unmuted.
may I request President IMA Kalyan, Dr. Prashant Patil, to brief today's CME. Is it there? Dr. Prashant Patil?
Hexagon team, please join.
Sangle sir, you have to unmute.
Am I audible now?
Yes, sir.
Yes, yes.
Yeah. Please
Sorry,
continue.
there was some connectivity problem. Thank you, Pillai sir. Thank you very much. Now I request Dr. Ramchandani sir, Joint Secretary CGP IMA Maharashtra, to introduce today's speaker number 1. Over to you, Ramchandani sir.
Thank you, sir. I welcome Dr. Anand Bhave, Dr. Priti Pillai, who are from Thane, and they have been very helpful during the COVID times and all. Welcome, Dr. Bhave. We'll start with you. Dr. Anand Bhave is an MD consulting physician at Jupiter Hospital, the director at Param Hospital, and his own ICU unit at Param Hospital. He's a ex-associate Honorary Professor at Mumbai University. He's a member of the Thane COVID task force, and during the COVID time, he was the topmost for a help and other associate. He is an executive chair at MEPCON and RSSDI State Conference, presented research papers on blackwater fever and exchange transfusion for severe malaria, delivered large amount of lectures on infections and diseases. He's been helping in IMA Thane, where he is associated with me as a scientific conferences. For any second opinion in Thane, everybody goes to Dr. Bhave, who is always the helping hand in our conference. Thank you, Dr. Bhave, and welcome to address Dr.
Thank you so much,
Bhave.
Dr. Ramchandani, for very kind words. And congratulations to CGP for choosing such an important topic and burning topic. So we will, in short, review what we all doctors need to be aware of about the new upcoming epidemic. I'll start sharing my screen. So basically, we are now faced with an emerging infectious disease, monkeypox, and as yet we don't know how far it will go, how much it will spread, how rapidly it will spread. But it is always important for doctors to be aware of what is happening around them what infectious diseases are likely to come. And with that aim in mind, it is important for every one of us to be introduced to this upcoming emerging infection. So I'm going to cover two aspects of this. One is how to identify the illness, and secondly, where did it come from, how did it spread, and about confirmation of diagnosis, how to prevent it and treat it. Dr. Preeti is going to cover in the next talk. So this patient is likely to present to a family physician or to a consulting physician, or he may present to a skin specialist because of either rash or because the skin specialist traditionally look after the sexually transmitted disorder also. So the onset of the disease is with typical febrile illness, acute illness. There is fever, intense headache, muscle pain, body pain, which points to onset of a viral illness with lot of fatigue. And this invasive or prodromal phase may last for 3, 4, or even 5 days maximum. An important feature here is the enlargement of lymph nodes. They may be local, that is only submandibular or axillary or inguinal or even generalized. This lymph node enlargement, which may be tender, and it is an extremely important point if it is present, because it will help us to distinguish monkeypox from some of the other similar looking viral illnesses. Another point to note is that about 3 or 4 days of this prodromal illness, which is quite severe, as compared to say a beginning of chickenpox, where the prodromal illness is milder, it may be a differentiating factor. But of course, the most important sign for monkeypox is, of course, the rash. The rash appears within 2, 3, 4, or 5 days after the fever starts, and it proceeds through typical stages like smallpox rash used to proceed. First, there are macules, which are basically flat reddish lesions, then papules, which can be palpated. Then next stage is vesicles, which are basically fluid-filled bubbles. And then they go on to pustules, where the bubbles are filled with a turbid sort of looking fluid. Finally, this breaks down and the skin gets ulcerated there, and then a scab forms over it. Then later on, these scabs also fall off, and healing begins. But it is like possible that deep scars may be left behind. Where does the rash come? It is described as a centrifugal rash that is mainly peripheral. So face is almost invariably affected, hands, legs, and the classical description is rash on the palms and the soles, where very few diseases cause a rash on the palms and the soles. The oral mucosa is often involved, and you may get ulcers in the mouth. The conjunctiva may be involved, so irritation in the eyes, and more dangerous, if it can cause ulcerations on the cornea, it can even lead to blindness, like smallpox used to do. The current epidemic has mainly involved the anus, perianal region, and the genitalia, as we will see later. Now, this set of pictures is from the website of CDC USA. It shows the early stage of the vesicle, then going on to form a pustule. Then that pustule has umbilicated. Picture C shows umbilication, that is a small pit in the center of the pustule. These are small ones, 3 to 4 millimeters in diameter, but they can grow very big in size. Then the ulcerated lesion. Now, if there are many pustules side by side and they ulcerate together, it can form a big ulcer on the skin. Eventually, that leads to crusting of the mature lesion with formation of the scab, which later on falls off. The number of lesions can be extremely variable. There may be very few lesions, or there may be even 4,000 or 5,000 lesions on the body, as this picture shows you so many multiple big lesions. So lesions may be a few to 1,000 in number, and they may coalesce together and cause large skin ulcers. The boils, or what we can call them pustules, are often painful, and then later stages and the scabs form, they can be very itchy. The rash lasts for a pretty long time, longer than the chickenpox rash. The chickenpox rash lasts about a week and then starts healing, whereas this rash may go on for 2 to 3 weeks, and the patient is infective for all those 3 weeks till the last scab has fallen off and skin has healed. In fact, the duration of this rash is one point where you can distinguish it from chickenpox. There was a case in Delhi where the dermatologist first saw this lady patient, and in fact, she was under impression it was chickenpox. But after 1 week, when the patient came back, the rash had increased and spread, and then the doctor realized it could be monkeypox, got it tested. Now the doctor herself is also in isolation because she has had contact with the patient, and this prolonged isolation period for the patient and for the contacts is a major headache in this illness. One of the characteristics of the rash is that in any given region, that is on the face or on the hand or on the leg, in one area, all the lesions seem to begin together and go through the same stages together. These are some additional photographs, multiple lesions on the face with showing the umbilication, then the large pustule on the hand. You can see how large they can become. Another distinguishing point, these seem to be larger on an average as compared to chickenpox pustules. More examples on the hands, on the back also, and on the palm of the hand, which is quite typical for monkeypox. Now, what we have looked at so far was the standard description of monkeypox. But the current epidemic, which is spreading in 2022 in the USA, Europe, and many other countries, has been of a different nature. The rash and pain has been starting or concentrating in the genital areas or perianal, and in some cases it has not even spread to the face and the limbs. Presentation has been by anorectal pain and tenesmus, which is a sensation of constantly having to go to pass stools but unable to pass stools, PR bleeding, proctitis, local pain, and local rash. Then the fever and the typical signs like lymph node enlargement, headache may come later, and the beginning will be with a anorectal or genital rash and pain. And in some patients, that generalized illness may not come at all. Asymptomatic patients seem to be uncommon. Now, this description in detail was given or reported in New England Journal of Medicine in this paper by John Thornhill, where they studied monkeypox virus infections in humans across 16 countries, and another paper describing the clinical features and novel presentations of human monkeypox in London by lead author Atish Patel and others in British Medical Journal. So their conclusions were this. The British paper said that the mean age of participants was 38 years. They studied 197 patients, and out of them 196 were gay, bisexual, or other men who have sex with men. All had mucocutaneous lesions, mostly on the genitals or perianal areas. There was systemic illness, fever, myalgia. Some of them were infected with HIV and some with other sexually transmitted diseases. Similarly, in the New England Journal, they reported 528 infections diagnosed between April 27 and June 24 at 43 places in 16 different countries. And again, most overwhelming majority of the patients were gay or bisexual men with a median age of 38 years. Now, this gives the impression that monkeypox seems to be spreading as a sexual transmitted disease, but that is not the case. We know that it can occur in heterosexual individuals. It can occur without sexual intercourse. It can occur or spread through other contacts, physical contact, contact with the scabs, the rash, etc. So we have to be prepared to diagnose both forms of the disease. Now, again, these pictures provided by the British Medical Journal article, rash all over on the trunk. So we just said that a centrifugal rash, but here the rash is on the trunk and widespread. Rash originating from the perineal region. Again, extensive rash on the back and in the oral cavity. These are pictures from the British Medical Journal. These pictures show the evolution of the rash, as you can see on the face and on the nose, eventually going on to scab, rash on the hands, starting as vesicles and pustules, and then eventually scab and a scar left behind. And the bottom panel shows the evolution of the rash in the penile region. And there are several images where extensive rashes and ulcerations on the penis have been found. This is another slide showing evolution of the cutaneous lesions. The virus can be detected from the vesical fluid or from the pustule or from the scab by PCR. So the rash seems to evolve quite slowly over number of days and may go on, even as you can see on some of the pictures on day 28. There is still a large ulcer, although the PCR has become negative, but the ulcer takes time to heal. So it is often described as, a benign illness or which doesn't kill too many people, but you cannot take it lightly. You can see extensive scarring, scabbing, and the rash going on for 2 or 3 weeks. And the persons become quite ill and they are also prone to some complications, which we will see later. Another slide showing extensive perioral lesions, intraoral lesions, lesions on the tongue and inside the mouth. This current pandemic in USA and Europe was, as we just saw, affecting the genitals and perianal regions. As you can see, all these photographs, extensive involvement, anal, perianal, and genital regions. Now, there are many diseases where you can get vesicles or even pustules, and they can confuse the picture. For example, herpes simplex can have oral and genital painful lesions. In the first attack, fever is there in primary herpes, but not in the recurrent diseases. And you can diagnose it by an HSV PCR test. Chickenpox is probably the most closely resembling disease, which is common in the community. Lymphadenopathy is a distinguishing feature. It's found in monkeypox and not in the other pox-like illnesses. Chickenpox lesions are in different stages of evolution. As you can see on the back, there are some which are macules, some papules, some have fully developed vesicles and pustules. And the chickenpox lesions tend to be a little smaller in size and they are more superficial looking, whereas the monkeypox lesions are deep-seated and larger. And there are so many similar diseases, like, for example, when a disease is limited to the genitals, then it can resemble a sexually transmitted disease, like lymphogranuloma venereum or chancroid. Fever and rash on the hand, foot, and mouth, that's a separate enteroviral disease, hand, foot, and mouth disease. It's pretty common. A secondary syphilis rash can be very extensive. It can affect the palms and soles, and sometimes it can also show vesicular and pustular type lesions. The other poxes are less likely to be entering the differential diagnosis here because they are localized rashes. And sometimes a blistering skin disease may also confuse the picture. This is a case of secondary syphilis with maculopapular rash on the feet. Now, this set of photographs has been kindly provided by a good friend of mine, Dr. Praveen Bhujbal from Kalyan. This patient, again, a confusing picture. There is a rash on the feet. Already you can see the vesicles there, which definitely needs to be, I mean, monkeypox needs to be thought of in this case. But there will be a differential diagnosis, hand, foot, and mouth disease, or even beginning of Kawasaki disease. So the differential diagnosis can be quite taxing. And what is going to happen now, as number of cases of monkeypox will slowly increase. But as physicians, we are going to face this dilemma more and more often of when to suspect monkeypox. So in my opinion, it is urgently required that ICMR and the private laboratory chains quickly standardize the PCR tests and make them available through various chain of laboratories all over the country, so that we can quickly determine and rule out monkeypox in such kind of illnesses. This is a patient I just saw 2 days back. It is chicken pox, but the resemblances are there. The palms are spared, but you can see on the base of the thumb there is a vesicular lesion on the scalp, and that ulcer on the gum. So this is going to become more and more confusing in the near future, and we definitely need access to the PCR diagnostic test for monkeypox on a bigger scale, because we can't keep on collecting and sending samples all the time to NIV Pune. Now, where did it come from? Where did monkeypox come from, and how does it spread? The origin of monkeypox is from Africa, but there are two viral clades, or two types of monkeypox which have been known in Africa. The central part of Africa, which you see there, Democratic Republic of the Congo, then Chad, Central African Republic. In this region, the serious version of monkeypox has been known, and it is a zoonosis, that is a disease which affects wild animals. And from contact with the wild animals, either through their feces or by contact through the skin, or even while hunting or catching them, the disease has affected people in this region. And there's a second version of clade 2 type of the virus, which has affected western parts of Africa like Ghana, Nigeria, Niger, etc., which is a milder version of the disease. The mortality in the central African variety of monkeypox reached as much as 10 to 11%, but the mortality in the type 2 clade in Western Africa was much lower, about 2 to 3% at most. And the epidemic which is spreading now seems to be related to this milder version, clade 2, but it is not exactly the same virus. There's already, the virus has changed. So the disease is endemic in Africa. Clade 1 is found in the Congo basin, which is severe. Clade 2 is in West Africa, which is milder variety. And the current epidemic, it has not been officially named as clade 3, but it may be named as that. It is similar to the Nigerian clade 2, but there are already several DNA mutations suggesting that this variety has been quietly spreading because of travel and other reasons throughout the world, but it has undergone DNA mutations to adapt to human transmission. Now, monkeypox can never be eradicated, even if you vaccinate lots of people. Why? Because it's not primarily a disease of human beings. It has a large animal reservoir. It's a disease of probably of rodents, rock squirrels, Gambian pouched rats, dormouse, tree squirrels, porcupines, striped mouse, etc. So these are supposed to be or thought to be the reservoirs, and it is not even a disease of monkeys. Monkeys and humans are incidental hosts who may be sometimes affected. Then why is it named monkeypox? We'll come to that. These may be the natural hosts of the disease in the African jungles: Gambian pouched rat, the rope squirrel, and the dormouse. So this is a disease where the virus was discovered first in the 1950s, 1958 to be precise, and it was isolated in monkeys who were actually to be taken for polio experiments. But they developed this rash and the virus was isolated there in Denmark. And this virus was subsequently shown to affect human beings in the Congo in 1970s, when they found 59 cases with a 17% fatality rate in young children. And there the infection was a zoonosis acquired in the rainforest from rodents and squirrels and other animals via urine, feces, or through the flesh of the animals, or through the bite of the animals. Now, the smallpox vaccine protected against monkeypox also, because they are from the same group or orthopox group viruses. But when smallpox was eradicated in 1977, vaccination coverage was stopped in various countries from 1980 onwards. So now, since then, almost 40 years have gone by. So now there is a large percentage of the population, the younger set of the population, who have not received the smallpox vaccine. Plus, the immunity in the senior citizens, those of us who have been vaccinated by smallpox, the immunity may already be on the decline. And hence, this monkeypox virus has probably gradually started spreading. And first, the cases increased in Africa itself, where it was already endemic. And then it has started spreading all over the world. So in the Democratic Republic of Congo, in the 2005 to 7 period, there were 760 cases. In 2017, there was a fairly large outbreak in Nigeria. And this year, it has already been found to be endemic in many, many African countries. And in the Democratic Republic of Congo, there have been more than 1,000 cases with 58 deaths. But it is a fact of life that diseases which affect the poor countries and the poor communities are not given much importance, not much research takes place. There is no much development of vaccines, and in fact, they are not being paid enough attention until now. The disease has started spreading all over the world, when suddenly it is attracting more attention. These are very cute animals called prairie dogs, but they are not dogs, they are rodents, like rabbits, a smaller version. They are found in North America, and they are very intelligent creatures. They make deep burrows underground with multiple pathways and chambers, and they cooperate with each other. They greet each other like this by kissing each other, and they warn each other of incoming predators, etc. Now, these creatures are used to be rather popular pets in America. And why we are talking about them is that they were responsible for a major outbreak of the disease in North America. In 2003, in the USA, there were 71 cases suddenly of monkeypox with 35 lab confirmed cases. Where did they come from? These patients had purchased these prairie dogs as pets. And these pets in the pet house had been stored close to imported African rodents like the Gambian rats. In the pet house, the rats infected the prairie dogs and the prairie dogs infected their owners. And even the vets who treated these animals were also infected. But doctors who treated the patients did not get infected. So probably suggesting that transmission from animal to human is much faster than human to human. But human to human transmission is known, recorded, well documented. And there is a almost 10 to 11% chance of household contacts getting infected. Now, in this current epidemic 2022, thousands of people from a dozen countries have contracted monkeypox. Number of countries has now gone up to about 70 to 80 countries. majority have been gay. The transmission has been by close physical contacts, but respiratory droplets, body fluids, and scabs have also been infected. This is the current monkeypox map, and you can see that every continent has now cases. The blue ones are the endemic zones in Africa, and the orange ones are the non-endemic countries where now the disease threatens to spread and become endemic. So in the non-endemic countries, the US has diagnosed the maximum cases, 9,500, followed by Spain, 5,000, and the list goes on and on. And in the endemic countries in Africa, the Congo has 100 cases, Nigeria 157, and some cases in the other countries. The numbers are climbing. As you can see, the worldwide graph, now there are already more than 30,000 cases this year from January to July. And this is the score as of yesterday, 32,000 reported cases. But if you include the African endemic countries, number is 34,000. There have been 7 deaths, but the deaths in Africa are far more. They are probably from the dangerous clade 1 variant. So the total deaths, if you count those, are 111. But then most of them are from a different clade of virus and not the current clade. So it is definitely something new. These numbers have never ever been seen in history. Non-endemic countries are getting affected for the first time, and that is why WHO has already classified it as an emergency. And it is a duty of all doctors to know about this and be prepared about this. The incubation period varies, but maximum is 21 days. Now, the implication of that is if somebody is in close contact with a patient, then that person will have to be observed for 21 days before saying that you have not got the infection. Who are at more risk? The children, immunocompromised people, and malnourished people are at greater risk. And will it spread in India is $1 million question. Definitely, there's nothing different about India. It is likely to spread. Obviously, it is spreading far more slowly as compared to, say, COVID. But again, all of us need to be prepared. Complications that can occur are secondary bacterial infections in the skin. Then there can be pain in the throat because of oral lesions and difficulty in swallowing with malnourishment. Bronchopneumonia, deaths due to encephalitis have been reported. Sepsis can occur. A dangerous complication is a corneal infection with blindness. And probably we don't really hear of viral abscesses very commonly, but it can cause abscesses in the muscle, and there have been reports of retropharyngeal abscess. And even if none of these complications occur, and we say it is not a very serious disease, what about the scarring? Because there are deep-seated blisters and pustules, and they can leave scars behind with disfigurement. I have been referring to all these articles. In fact, one of the articles was written by my friend in Thane API, Dr. Kohli and others, an editorial in this journal, JIMSA, Monkeypox 2022. The Ministry of Health and Family Welfare, Government of India has published guidelines for management of monkeypox. Clinical infectious disease article on emerging infections, and the studies which I quoted from New England Journal of Medicine and BMJ, plus an older article from the Lancet, and of course, up to date. Thank you so much.
Thank you, Dr. Bhave. Dr. Pradeep Sangre.
Thank you, Bhave sir, for such a informative, lucid, and comprehensive talk on the subject. Thank you very much. Now we will proceed further. I'll request Ramchandani sir to introduce our today's second speaker, Priti Pillai madam. Over to
Is
you.
she on the panel? Dr. Priti Pillai, is she there? Madam?
Yes, yes, I'm here, sir. Just 1 second.
Yeah, sure.
Yes, yes, I'm here.
Okay.
Can
Welcome,
you
Dr.
allow
Priti.
me to share the screen?
Yeah, please share the screen.
Just 1 second. Can see my screen?
Okay. Yes, now we can see it.
Start the slideshow.
Yeah, you can.
Ramchandani sir, please introduce madam.
Yeah.
Thank you. IMA
Yeah.
Maharashtra CGP.
Ramchandani sir,
Yeah.
please introduce
Okay.
madam.
Welcome, Dr. Priti M. Pillai. She is a consultant and an infectious disease specialist at Jupiter Hospital, Thane. And she is also attached to Bethany Hospital, Thane. Her experience of 9 years as an infectious disease consultant and practicing in Thane for the last 6 years. Publications, she has a textbook chapters and 3 and 4 other on pneumococcal infections in 12th, 11th and 12th editions of her API textbook of medicine. And she has created acute viral syndromes in ICU under in textbook of critical care. Her areas of special interest is HIV medicine, transplant infections, and infections control and tropical infection. Welcome, Dr. Pillai. Please go ahead.
Thank you, sir, for the invite, and thank you, IMA Maharashtra State, for inviting me to present this topic. To take you through my talk, I'll be talking about lab diagnosis, prevention, and management of monkeypox. So that agenda is, first I'll speak briefly about the clinical diagnosis, then which Dr. Bhave has already covered, lab diagnosis about sample collection, transport and processing. How do we prevent monkeypox in hospital and in community? Then in a short about management and post-exposure vaccination. So as sir has already mentioned, monkeypox is a febrile illness associated with a acutely progressive rash from macule, papule to vesicule, and then a pustular rash associated with lymphadenopathy and caused by a type of orthopox virus called monkeypox. Now, who is a clinical suspect? Any febrile patient who presents with rash and lymphadenopathy with recent travel to affected countries or who are close contacts with confirmed or suspected cases. So this is the health advisory recommendation from Government of India. A suspected case is a person who has traveled to affected countries within the last 21 days and presenting with an unexplained acute rash with lymph nodes, swollen lymph nodes, fever, headache, body aches, and profound weakness. A probable case is a person meeting the case definition for suspected case, that is a clinically compatible illness and an epidemiological link like a face-to-face exposure, including healthcare workers without appropriate PPE. A confirmed case, a person who has had a laboratory confirmed monkeypox identification either by PCR or sequencing methods. So what's a differential diagnosis? Now, before we come to diagnosis, when do you suspect it? Sir has very well gone through the entire clinical syndrome. So who are the patients in whom we suspect? So our routine OPD patients in whom we see chickenpox like rash or a hand-foot-mouth disease, secondary syphilis, disseminated herpes zoster, measles, pyoderma, autoimmune conditions leading to vesicular eruptions, including also drug rash and rickettsial pox. So the presentation predominantly for a generalized monkeypox disease will come to our general physicians, our internist, our dermatologist, and including also rheumatologist and specialized, a limited disease may be present to gynecologists, urologists, and surgeons as well. So it's important to remember for all specialties about monkeypox. So the characteristics specific to monkeypox is the most important thing, presence of lymphadenopathy with a febrile rash. And the rash is typically deep, hard, umbilicated lesion progressing to macule, papule, vesicle, pustule, and heals by scarring. Predominantly, they have monomorphic stages versus pleomorphic stages in chickenpox. Has a centrifugal distribution and predominant involvement of palms and soles. Has a long febrile prodrome. Some patients may have limited lesions, which sir has already alluded to, which includes genital region involvement, mucosal involvement like oral lesions, conjunctival lesions, painful pharyngitis, proctitis, who may present to surgeons, ENT specialists, gynecologists, urologists. So a high degree of clinical suspicion is needed. Just 1 second, can you just, sorry. So how do we confirm that? How do we confirm? So any clinical suspect presenting with such cases, we need to confirm it by PCR. That's the only way to confirm the diagnosis. So confirmation by RT-PCR from lesion material or by oropharyngeal or nasopharyngeal samples. It's important to remember that the viremia period is too short to diagnose from blood PCR. So sending blood PCR for monkeypox may not really help, even when these tests are commercially available. The most important clinical sample is a lesion material. And serological tests, though are available under research, may not be clinically available soon. So the important diagnostic modalities are basically PCR-based diagnosis. Apart from that, under research, viral culture isolation, electron microscopy from histopath samples, serological tests, including antigen-based tests, are available, but may not be useful. So what we rely on are PCR-based tests and sequencing. Now, what are the samples that you should be sending? Most important is the lesion aspirate or scraping from lesion, oropharyngeal swab and nasopharyngeal swab. And our guidelines from government also recommend sending urine and blood samples. How is sample collected? Important thing is, in asymptomatic patients, we just observe them and do not subject them to any sample collection. Symptomatic patients require sample collection from the lesions, that is the lesion roof or scrapings or aspirations from the lesion, along with nasopharyngeal or oropharyngeal samples, along with blood and urine. And if the patient comes to you after the lesion has healed and scarred off, in the recovery space, blood and urine may be sent, but that's as part of, it's more for academic interest, but it's unlikely to yield results, especially blood, but maybe urine may yield in patients who have got predominant genital complaints. So important for hospitals and would be how a sample should be transported. Given that the disease spread by close contact, it's important that all people who collect the sample should be in a full PPE, which includes gown, gloves, mask. The sample should be sealed off properly and kept in a secondary container with absorbent-proof material. And it is sent to NIV Pune, who initially screens it for the presence of orthopox virus. And if the specimen shows orthopox positivity, then specific PCR panel for monkeypox is done to confirm the diagnosis. As of now, it's available only at NIV Pune. So after the diagnosis, so the important aspect of diagnosis is that you have to send the lesion material. Our recommendations are also to send blood and urine along with the lesion material. And the next important aspect of my talk is prevention, both in household and community settings, as well as in nosocomial setting. So before we understand about prevention, it's important to know what is the transmission dynamics. Knowledge about transmission is what will help us in preventing the disease. So infectivity is from 1 to 2 days prior to rash developing until all lesions scab off. So we know that the rash can evolve over up to 10 days or even up to 2 to 4 weeks. So the period of infectivity may range depending upon the evolution of rash. So it may easily go on for 2 to 4 weeks. And the incubation period after an exposure is usually from 6 to 13 days. So a suspect or a high-risk exposed patient without any PPs should be isolated for, should be observed for 21 days for development of symptoms. And if any symptoms develop, they should be isolated till they are till all the lesions completely scab off, for prevention of transmission. And now what are the modes of transmission? The modes of transmission firstly are droplet. Droplet means through large respiratory droplets. So how do you prevent droplet transmission? That is by use of 3-ply mask and respiratory etiquette. Then the next most important modes of transmission is through contact. So it is close skin-to-skin contact and contact through lesions or use of used beds, linens, etc. So direct contact as well as through fomites. This can be prevented by use of gloves and gown. And the other thing is important aspect is standard precautions, which again is based on risk of exposure to body fluid. So what you have to use is Gloves, mask, gown, gloves and gowns are mandatory, and mask, eye shield during aerosol producing procedure. So in hospital, what we are looking at is use of mask, gown, and gloves become important, and these patients should be isolated in single rooms, and the immediate surroundings should be cleaned on a regular basis, and the use and their beddings and linen, all the materials should be disposed of safely to prevent fomite based transmission. The other important modes of transmission is through vertical transmission. uh, just excuse me for a minute, just 1 second. Nahi hai class. Sorry, I'm so sorry. Other important modes of transmission is vertical transmission. This has been described in all the outbreaks that has been explained. So sudden fetal transmission and sudden fetal death and stillbirths are known. So that's important when we are dealing with pregnant ladies with vesicular rash. So important to remember the possibility of vertical transmission to the fetus if a pregnant lady is affected with the disease. So how do we prevent in hospital settings? Patients should be isolated in single rooms. They should be using dedicated items. So their BP apparatus, the stethoscopes, all those things should be dedicated to that patient and should not be used to other patients to prevent cross transmission of infections. Environmental cleaning of high touch surfaces would be important, and appropriate PPEs, that is use of gloves, gown, and mask based on risk of exposure. Given that it is a droplet transmission, contact transmission, use of mask, gown, and gloves are must for routine care of the patient. And when we do close contact care, like a nurse providing sponging, nurse providing cleaning of those lesions, or the dressing, or any surgeon evaluating the patient, they should have a full PPE to ensure any kind of further transmission based on close contact. How about in communities? So affected individuals should isolate till all lesions crust. So since it is described as a disease with a self-limiting course, most patients may be isolated at home. So it's important that these patients are isolated till all lesions crust. And importantly, if they have very limited lesions, then these lesions should be covered to ensure that it doesn't spread to others. Caregivers should wear mask, gown, and gloves and wash hands frequently. Avoid skin to skin contact till all lesions scab off. This is very important, that what we are seeing in the present outbreak, with wherein there is a lot of diseases being described in gay and gay individuals and MSM group. The most important reason for the spread is predominantly skin to skin contact. There has been no clear cut confirmation that it spreads by body fluids. More importantly, it is due to the close skin to skin contact that leads to the spread of infection. So it's important to counsel about these things as well, including prevention of to abstain from sexual contact till all lesions completely scab off, and use of dedicated personal use items. So the personal toiletries of the patients and the use of bedding, clothes, and linen should be completely segregated to ensure that there is no cross transmission within the house. And in community, use of public washrooms and all. So it's important that people use washrooms and commode seats after prior cleaning and sterilization to ensure that there is no community transmission of the infection, given that there are a lot of pure limited genital lesions in our community, in the community wherever it's been described as outbreaks. Next, I'm talking about this treatment. So important to remember that as such, now there is no special antiviral that's needed for most patients. It's essentially supportive. So most patients have a self-limiting course, which may range from 2 to 4 weeks until they completely scab off. All they need is fever medication and pain relief medication. It can be extensively painful, especially when the lesion evolves and becomes scabs off. And then later on, it can be very itchy. So it's predominantly antipyretics, painkillers, and antihistaminics for itching relief. Protection of affected mucosal surfaces is very important, especially when they are painful throat lesions, painful oral lesions, or severe proctitis or conjunctival lesions where prevention of blindness becomes very important. The next important thing is prevention and treatment of secondary infections. Given the deep-seated lesions, these patients are at risk of getting secondary bacterial infections, including the usual skin problems like Staph aureus or MRSA. So it's important to prevent and treat. So skincare becomes very important when you're managing these patients. Antivirals are required in select high-risk patients. As of now, it's not available in India, And the high risk groups are people who are immunodeficient. In all the outbreaks that has been described in the recent past, the mortality has been described in immunocompromised patients, HIV patients, and in young children. So it's important that if at all, whenever antivirals are made available, it should be used in the high risk groups. So what are the supportive measures? For skin rash, it is cleaned with simple antiseptic. Use of mupirocin or fusidine. Cover with light dressing if extensive lesion. Do not touch or scratch the lesions, and prevention of secondary infections. For genital ulcers, sitz bath. For oral ulcers, warm saline gargles and oral topical anti-inflammatory gel. Conjunctivitis is usually self-limiting, but it's important to keep a close watch for sudden onset pain, blurring, and visual disturbance to prevent corneal scarring. It's important to maintain rehydration and nutritional support. So ORS, IV ORS, intravenous fluids if indicated, and nutrition support. Symptom elevation by antipyretics, anti-itching medication, anti-vomiting, and paracetamol. So these are the major supportive measures, and this is what most patients require. Complications of secondary bacterial infection. So based on the appearance of these lesions and the new onset fever or any kind of toxicity, we may have to keep a close watch for secondary sepsis, cellulitis, and abscesses. Based on that, broad spectrum antibiotics may be needed. If needed, drainage may be needed. So in the cohort of patients described in literature, a good number of patients require drainage for deep-seated abscesses. Possibly these are secondary bacterial, given that these lesions are quite deep. Then general skincare and nutrition. Other important complications that has been described are pneumonitis, including bronchopneumonia, encephalitis, and corneal lesions, which can lead to scarring and blindness. Here again, the important modalities of treatment has been general supportive care, antibiotics, and in corneal lesions, in corneal scarring, use of topical steroids. So what are the available antivirals? So there's a lot of this talk about use of antivirals. So this is a paper which came up in 2014 when there was a description of all these clusters in Western Africa and Central Africa. A lot of study was done in monkeypox, and based on the response to smallpox, these medications were described as for use in monkeypox. So we have cidofovir, which is available for treatment of CMV infection with great difficulty, but it's a highly toxic medication and it requires administration in intravenous form. Following that, there were two medications which, when this paper was published, it was under research, but now these drugs are available. The first is a brincidofovir, which is an oral preparation of cidofovir, which is an oral analog of cidofovir. It can be given as 200 milligram orally weekly. In the cohort of patients that were studied, it's important to remember that this drug had to be discontinued because of development of transaminitis. And if and when it is available, that is one option that can be considered. Compared to that, the next drug is ticovirimat, which is available as an oral therapy, which basically inhibits release of intracellular virus. It is available as an oral drug, and it was available in limited quantities previously. Now it is being used in certain countries after the new outbreak of monkeypox. The dosing is 600 milligram twice daily for 2 weeks, and it has shown good results in patients who are high risk. Both drugs are not yet available in India. In a setting where if an outbreak becomes a reality in our country, wherein we see severe patients, maybe at that stage, we may consider cidofovir till these drugs are available. But it's important to remember that cidofovir is limited by a lot of toxicity, including nephrotoxicity and neutropenia. It requires co-administration with probenecid. The usual dosing for cidofovir is 5 mg per kg weekly as a loading, followed by 2.3 mg per kg weekly. Important that it's highly nephrotoxic, and even in CMV disease, we are not able to give it for a long period. But that is one drug that is available to us if the monkeypox outbreak becomes a reality in our country. And if at all it becomes, I'm sure that we will be, in a short while, we'll have access to the other oral safer drug, which is ticovirimat, which is available as 600 mg preparation twice daily for 2 weeks to be administered. The recommendation is to give only to high risk groups like immunocompromised and HIV-positive individuals. Now, the next important aspect of treatment is also post-exposure prophylaxis by vaccination. So as Dr. Bhave has already mentioned, people who were vaccinated for smallpox has got good immunity So that is the premise on which we are using post-exposure vaccination, or there is a consideration for post-exposure vaccination in high-risk group. So smallpox vaccination is protective. Modified vaccinia vaccination being considered as post-exposure prophylaxis in close contacts. So far, it's not available in India, but it's been made available in US and European countries based on the present outbreak. So these are the various vaccines available. So the ACAM 2000 is basically our the first generation smallpox vaccine, which is a vaccinia virus. If most of you know that it is a single dose administration with a local pox-like reaction, which happens, and there are a lot of issues with smallpox vaccination because it is a live vaccinia virus. It is not recommended for monkeypox vaccination. What is recommended is a second and third generation modified vaccinia virus, that is the IMA-Mune and IMA-Next, that is modified vaccinia Ankara, which has got limited replication. So though it is a live attenuated virus, it has got less replication potential, and it doesn't behave like the early generation smallpox vaccine. And the next other vaccine is the LC16 attenuated vaccinia virus, which is available in Japan. That is a single dose administration vaccine, and again, it has got a low replication potential. So it's licensed to use in Japan, while the modified vaccinia is available in US and European countries. So this is the CDC interim recommendation, which has come up in August with regards to monkeypox post-exposure vaccination. This is essentially the second generation smallpox vaccine, which has got zero replicating potential. It is available as a subcutaneous vaccine, 0.5 ml, 2 doses separated by 28 days. The usual reactions are local local injection site pain, and very rarely pericarditis, myocarditis has been reported as a potential side effect. This has come up in CDC's interim recommendation for high-risk individuals for post-exposure prophylaxis and for occupational risk in lab personnel, as well as in an outbreak situation for healthcare providers who are at high risk of acquisition of the disease. Coming to the WHO recommendations, WHO has clearly given a recommendation that there is no need for mass vaccination of all. Pre-exposure vaccination is recommended in high-risk occupational group who are working with orthopox viruses, like the research facilities or lab techs dealing with sample handling and diagnostic services if it becomes an outbreak. In outbreak situation, high-risk healthcare providers may be given based on the local. So if our national guidelines come up with post-exposure vaccination for healthcare providers, then it will become a mandate. Otherwise, as of now, it is not being recommended, but it may be considered as per WHO recommendations. The post-exposure prophylaxis, or what we call as a ring vaccination. So this is in patients who are, say, somebody who is confirmed with monkeypox, and the close contacts like the family members or people who are high-risk close contacts may be offered this vaccine. It's important to remember that this is still not available in India, but it is being recommended in US and Europe, wherein the high-risk contacts are offered this vaccine from 4 to 14 days from exposure for prevention of disease. So this is quite like what we do for chickenpox. So if somebody who's exposed to chickenpox but has not had the disease and who is not pregnant, we offer them post-exposure active vaccination. Similar to that, for the monkeypox, a post-exposure prophylaxis may be offered to high-risk groups like pregnant patients, children, and immunodeficient hosts. Now, it's important that this is a live attenuated vaccine, but the second and third generation vaccines do not have any replication potential, and that's the only reason why the high-risk groups can be offered this vaccine. So, if at all it is clinically appropriate, and if the person is high risk, these vaccines may be offered to high-risk contact as post-exposure prophylaxis. The choice of vaccine is MBAB, and that is a second generation smallpox vaccine, or the LC16, which is right now only available in Japan. So the take-home messages from my talk is clinical vigilance in suspecting monkeypox in patients is paramount important to diagnose these patients early. So we should be working up febrile patients with rash with oral or genital ulcers progressing to vesicles and pustules. Standard droplet and contact precautions are mandatory in healthcare setting when we're looking at an emerging outbreak. So it's important that when you deal in OPD with any kind of rash patient, any kind of vesicular lesions, or any febrile patient, Mask and gloves are a mandate, and if you're going to have a close contact examination with these patients, also wear a gown. That's the only way to upfront prevent infection. Thanks to COVID, we're all using masks, so it's important to reintroduce gloves and gown during contact with such patients. Prevent stigma to improve case identification. That is more important in the present outbreak, where a lot of patients have been identified in the MSM group and the GABE group. And because of this, these patients are not coming to formal doctors and ends up going to quacks or do not get identified. And the outbreak keeps on happening in the community at a subclinical level. So it's important to prevent stigma and improve case identification, because unless and until we send these samples to NIV, we'll never know whether we're having the disease in our community. And unless we diagnose it early, we will miss that, the bell curve, the early part of the bell curve where the number of cases are less. By the time we see an explosion of cases, we would have missed the bus in introducing preventive measures. Supportive care and monitoring for complications remain the mainstay treatment. Antiviral use and post-exposure vaccination may be needed in high-risk groups, but availability in our country is an issue now. So thank you for your patient hearing. So that's all from my side.
We are really grateful, madam, for enlightening us on the subject in such a detailed and nice manner with beautiful take-home messages. Thank you very much. We will now move to the next question and answer session. For that, I will request Dr. Bhavika Uchchandani, madam, who is Joint Director of Faculty of CGP IMA. Over to you, Bhavika, madam.
Thank you, sir. There's one question on the chat box. Will AC work skin cream help for the skin lesions?
Ma'am, sorry, I missed the first part of your.
Will AC skin cream help for the skin lesions? So basically the acyclovir skin cream.
Acyclovir.
Ma'am, I don't think so, because just like CMV, for us like CMV treatment, we can't give acyclovir. Similar to that, I don't think, because it's a different group of virus. It's a DNA virus. I mean, it's entirely different. Even though CMV is also a DNA virus, it's an entirely different group of virus. That is a herpes group of virus, and this is a different group. So we don't expect. And if it was really working, it would have come in the recommendations. So they must have found that it doesn't work. That is why we have a different set of antivirals being used or recommended.
Yeah. Second question is from my end. Suppose a GP diagnoses or suspects monkeypox. So how is the process of sending the patient for NIV, and what is the process to inform BMC for a suspected, and how much of isolation is required?
So basically, till the result comes, that person needs to be isolated because we're not sure. And those isolation measures are what we have described already. The process has been clearly given in the government guidelines. So they have even given a list of numbers to be contacted. As of now, the primary center is NIV Pune in Maharashtra. There was a mention in between that even Kasturba will be starting the test, but I'm not sure it's still available. But there is a list of numbers and how it needs to be sent in the government guidelines, which has been circulated to all hospitals as well. So all the hospitals have adopted that, and it's part of their policy. Monkeypox outbreak analysis.
I asked you whether for the GP, the hospitals have the guidelines.
We'll have to
for a GP, should they inform their local MOH office, or is the process, or are there any forms to be filled?
So yes, there are certain forms. It's available with this guideline. Is freely available for download. So we all of us should have that with us, and there are a list of numbers provided, so we can get in touch with them and then send it across. How the sample needs to be sent, that also is being given in samples, how it should be transported, including storage at 4 degrees Celsius, and send it in an ice pack with a double container. So once you've collected it, you seal it off. Then it is kept in a secondary container, and between the first and the second container, there has to be a absorbent cotton pack. There is no spillage. One thing needs to be kept in an ice box at plus 4 degrees Celsius, and then transported to NIV Pune. And there are contact numbers provided. So at least in the guideline, it's provided. So you may have to get in touch with them.
There is one question by Dr. Dipti Pumble in the chat box, but I think you answered it. Do pathology labs do the PCR test currently? But you already answered it with an NIV.
Okay.
That's about the questions.
Yeah, hello. Myself, Dr. Rajan Mane. Hello.
Yeah,
Yes,
yeah.
sir.
Yeah, I just want to ask that Dr. Anand Bhave had mentioned that the scar formation is there post monkeypox infection. So, are these scars as severe as smallpox infection?
They are probably little less, but they can cause disfigurement because they are
Okay.
deep-seated. Yes.
Okay. Okay.
But can I ask a question? In an Indian scenario, before the patient comes, he's already lost 2 or 3 days to the GP. By the time the whole GP household as well as the patient's household are infected, do you think isolation of all these persons in contact would be possible in an Indian scenario?
So presently, isolation is only for the person who's affected with the lesion or with symptoms. Symptomatic isolation is not required. You have to observe them for 21 days for development of symptoms. The transmission dynamics in household clusters, the way we had in the early COVID, is still not determined in this outbreak. So all these things will come up only in near future. So somebody who's a contact but who's not symptomatic, that person requires observation for 21 days, but need not be isolated. But once the symptoms develop, that person needs isolation till all the lesion progresses, evolves, scabs off, and the scabs fall off. That is pretty long period.
Thank you.
Yeah, I just myself, Dr. Mane, I just want to know that in a patient who has already had COVID infection in the past, will be the monkeypox infection will be less severe or something? Is there any relation with that?
Really unrelated, two different viral infections.
Okay. Yeah.
Dr. Sanjay, please.
One doubt in my mind, we do see foot and mouth diseases patients. Is it possible to differentiate clinically between monkeypox and foot and mouth, or we have to go for lab testing? RT-PCR?
So you are answering us.
How to differentiate hand, foot, and mouth from
So the clinical profile looks quite similar. Only important thing is that hand, foot, mouth at least are more common in kids. So what will help us right now in the early part of the epidemic, early part of this outbreak, whatever we call it, is epidemiological links. So a travel or a contact is what will help us now. Or similar illness, like there has been an instance of somebody who traveled from India abroad and who developed febrile lesions and similar looking lesions isolated, and she's been branded as monkeypox. Hand, foot, mouth is in our country at least is quite limited to predominantly kids. We see very few adults coming with hand, foot, mouth, and the kids also, it's very specific to daycare, school. So there is a clustering of hand, foot, mouth when it happens in daycare, school. So by the epidemiology, we may possibly call it hand, foot, mouth. It happens in kids. But if the rash is progressive, evolving, because the hand, foot, mouth, though it is initially painful and a lot, but it starts becoming better very fast. Compared to that, monkeypox may go on for 2 to 4 weeks.
Yes.
Whatever descriptions we have heard. So a generalized monkeypox, maybe by the second visit when they come back to us, we know that we are possibly not dealing with monkeypox and dealing with something else.
Thank you very much.
What is the cost of the diagnostic tests?
Yes, sir.
What is the approximate cost of the diagnostic tests?
So as of now, I think it's freely available by NIV. As part of outbreak analysis, they're supposed to do it.
Okay.
And I don't know whether NIV is doing a charging.
Okay.
Not yet, sir.
Dr. Bhave, sir, you know about it because all the samples that's been sent, they're not, it is part of our outbreak analysis by the government.
Right. No, as of now, I don't think they are charging anything, but we'll have to find out. We have not sent any
I have
samples.
really not. There has been a couple of samples sent from Jupiter, but I have not understood the cost or whether, or maybe the transport cost is there, but once it goes there, they're supposed to do it.
But sir, if really we do get cases of monkeypox like COVID cases, then we'll require to have centers apart from NIV Pune also, no? Like other peripheral centers.
Yeah, that is what I think. There, rather than actual monkeypox cases, first we will have a surge of suspect cases. Because
Okay,
now
okay,
we
yes.
begin to see more and more, the routine chickenpox and others. Some of them will look like monkeypox and will want to send samples. So
Okay,
for
okay.
that purpose, I really wish that some private labs who have got a standardized equipment, they should be allowed to do the test so
Yes,
that
yes.
we are able to test more and more people easily.
Yeah,
You
yeah.
are absolutely correct that we
Yeah, yeah.
need private labs to
Yeah.
do the test.
So we'll have to do the similar logistical exercise as we did in the initial phases of COVID at the start
Only
of
thing
2020.
good about it is that it is not going to shoot up suddenly like COVID cases because
Okay.
it is not that highly transmissible like
So
COVID.
that is some
So we
relief
will
for
have
us.
enough time to prepare, but we should not take it lightly. We must be ready with the diagnostic.
Yes, yes.
Yeah. Dr. Sangle?
Yes, now we'll move to the Thanksgiving session. I'll request Dr. Rajan Mane sir to propose vote of thanks.
Yes, thank you very much, Dr. Sange. So I think we had very very educative lectures by Dr. Anand Bhave sir and Dr. Priti Pillai madam on monkeypox, because we are not really aware of the intricacies of the disease, and both of them have managed to throw some important light on this topic of monkeypox. So thank you very much, Dr. Anand Bhave sir and Dr. Priti Pillai madam, for your honorable lectures. Thank you very much. And apart from the speakers, I would also like to thank our IMA-MS officials. Dr. Suhas Pingle sir, our president, Dr. Mangesh Pate sir, our secretary, and Dr. Rajiv Agrawal sir, our treasurer. And of course, Dr. Ravindra Kute sir, who is the president-elect, and Dr. Londe sir, immediate past president, and Dr. Bandarkar, our past secretary. And apart from that, the whole IMA CGP team is very much, I would like to thank them for their efforts they have taken to arrange lectures on this new topic. Dr. P.S. Sanges, our director of CGP IMA-MS, and Dr. Rajan Sancheti, sir, secretary of IMA-MS CGP sub-faculty, and Dr. Ramchandani sir and Dr. Bhavika Hodchandani madam, joint secretaries of CGP IMA MS CGP sub-faculty. Our team from IMA Kalyan, Dr. Prashant Patil, President, Dr. Isha Pansare, Madam, our Vice President, and Dr. Ipca, Madam, Surekha Ipca, Madam, our Secretary, and Dr. Himanshu Thakkar, our Treasurer, have also been very cooperative in arranging this session. And now, apart from this, our team of this from Ipca, who have been working relentlessly to arrange this session. Miss Archana Wagmare, madam, who happens to be the zonal manager of Ipca, and Mr. Shashikant Giri sir, regional sales manager, and Mr. Ram Vijay Singh, senior area sales manager. They have helped us a lot in arranging this CME on monkeypox. And of course, with this, I'll hand over the session to Dr. Pradeep Kumar Sange sir for further proceedings. Thank you very much.
I would
All
also
the
like to
delegates,
thank
thank you for your kind listening and attendance. We hope to have the same patronage in the future as well. Thank you.
I would like to thank Dr. Rajan Mane sir also, and very nice to see my friend Dr. Ali Kausar Zaidi. Very nice to see you, sir. And I am very much grateful to each and everybody of you, all the speakers, Anand Bhave sir, who is always prompt in responding to these new entrant diseases. He immediately enlightens us, and Priti Pillai madam also, and everybody from my team, everybody for their presentation, and all the delegates which are not seen in this link, those who have joined, we are very much grateful to you. And with this, I declare today's scientific session is concluded. Thank you very much. Dr.